But I guess, Filipa, you will now take over and take on with your talk. And please introduce yourself, my dear friend. Tell us who you are.
So good evening to you all. I hope you're well. Astrid asked me to speak about HD cognitive changes from a professional point of view. As my background is in psychology and neuropsychology, and I've been working with HD families for some years now. And I'm also involved in the European and the Portuguese Association. So the idea of having this poll is just to hear your opinion about what is more distressful to you. And I think that we can learn from what Irene said and also from your answers that indeed it seems like the cognitive changes and the behavioral changes that are presented by Huntington's patients are much more distressful for families than, for example, the motor changes. And this was the idea of this poll. So you had three options. One was your loved one dropping things. The other one was your loved one getting really upset without reason. And the other one was your loved one being more sleepy than usual. And most of you choose the part of your loved one being upset and refusing to do something without any reason as one of the things that causes more troubles at home. So I will share my screen. Everyone can see this?
Yes.
Okay. So one of the things that I wanted to ask you, and it's important for this presentation, is to have a paper and a pen close by, because you'll need that. It's not an exam or a school test, but you're going to need that. So, yeah, I would like to say that, the main thing to start is that now, today, 21st century, we know that, and we have enough scientific knowledge to understand that human behavior is really connected to the brain. And does not happen out of the blue just because someone is mean or has a bad personality. So it's important to understand, and I said that before, that the behavior of HD patients is caused by brain changes that have an important impact on the way they move, they think, they feel, they act. And only by understanding what this is and what are the real problems can we address them. So going back to the basics, so to the brain, we know that HD is a neurodegenerative disease that primarily affects one region of the brain, that it's this one in this image called the basal ganglia. And HD particularly affects these structures in purple called the caudate nucleus and the putamen. So what HD does is causes damage and death to the neurons of these structures and of this region, and also damage the connections between these regions and other regions of the brain. And this region is responsible for things such as motor control or movement control, but also for things such as emotion regulation or executive functions. We know now also that these brain changes happen before the onset of motor symptoms and of the HD clinical diagnosis, sometimes many years, more than a decade before. So these structural and functional changes in the brain have consequences. And in HD, we can say that they can cause a triad of motor, cognitive, and behavioral symptoms. So this image tries to translate this idea. So if we look closer, we see that someone that has damage in the basal ganglia, this is the pink zone here in the brain, displays not only motor or physical problems, so problems with walking and with balance, for instance, but also can show increased irritability, which will make him shout with others, so it can cause several problems at home. So the thing with HD is it really affects all the domains, the thinking, the feeling, and the acting. And what is most complex in terms of not only clinical care, but also research, is to see that there is a huge variation in terms of the type and severity of these symptoms across patients and also across the disease span of one patient. This means that there are no two patients alike. So we can see that some patients experience more cognitive or behavioral symptoms and that fewer physical or motor changes, whereas other patients may present more chorea and are more balanced in terms of psychological mood. So this makes Huntington's disease particularly challenging. This is the main point. But we'll focus on cognition now. So cognition is the scientific word for thought process, for thinking. So it comes from the Latin word cognoscere, that means to know, to learn, to think about. And in Huntington's disease, we know now that there are indeed several cognitive domains that are impaired from very early on in the disease. Things such as executive functions, attentions, processing, speed, recall. However, it's important to understand that despite these domains being impaired, there are several other domains that are relatively preserved even in late stages of disease, such as orientation, recognition, or language. Orientation, for example, means that the patient, even in more advanced stages, is able to answer questions such as in which season are we or where are we? So he is able to do that. Recognition is the skill or the capacity to recognize between different options the correct option or the correct answer. And language, also HD patients have relatively preserved language skills. So although their speech is a little blurred and slowed, they know the words, so they know the name of things, and they are able to choose the correct words and understand what is being said and what is being requested. What happens is, in many cases, that the impaired cognitive skills plus the motor symptoms plus the behavioral changes will somehow disguise all the cognitive abilities that are still preserved. And so the patient seems to be much less capable of doing things or thinking about things than he actually is. On the other hand, sometimes also there are drugs and treatments that physicians prescribe, the neurologists or psychiatrists prescribe for the other symptoms, for psychiatric symptoms or motor symptoms that have a negative impact on cognition. So having all this in mind, it's important to find alternative strategies to reduce the impact of cognitive symptoms on the patient's life. To do this presentation, I based this presentation on a wonderful book by a wonderful person. It's called Jimmy Pollard, and many of you know him. And this is one of the best books ever written about cognitive problems in HD and ways to address these problems. The book is available already in many languages. In Portuguese, it is also. So you can get in touch with your association, with your national association, or just buy one book through this link. Lulu is the site. So we will speak about some of the cognitive changes that Jimmy speaks about in his book, and we'll speak about the slower thinking, the difficulty in recalling, the difficulty focusing and switching attention, the difficulty organizing and planning, and the difficulty with emotion regulation that many times patients display. So we'll start by speaking about the slower thinking. So if we have less brain cells or neurons, or have brain cells that are not working properly, for sure that this will affect our thinking process. And because we cannot see the thoughts, the way to become aware of this slowness is to observe the slowness of behaviors. So it's like you had a problem with your car, and instead of going at a normal speed, the engine is broken and you can only go at a very slow pace. So it's important to understand that the car is still working, but it did not stop completely. But the speed of the journey is not the same. It's much slower. So the time you're going to spend traveling and doing the journey will be much longer. So this will make you feel more tired, much more prone to distractions when you drive. The quality of driving is worse. You are much more able to have accidents, and you'll probably feel very irritated and even angry because all the other cars are passing you by and you don't seem to be moving. So the easy thing to do when you have this problem in your car and the car doesn't go any faster is just to avoid driving, decide not to drive at all, refuse to do the journey, or complain and feel irritated all the way long. So the idea, this is what happens to HD patients with daily life tasks, such as dressing up in the morning or preparing a simple meal or dialing a number to phone someone or filling in a form. So all these little things that we do on our daily routines, the patient is able to do them, but only at a much slower pace. This includes also, for example, speaking with someone, maintaining a dialogue with someone, because it takes the patient much longer to process the information and then formulate the answers. So conversation is also effective. So in conventional neuropsychological testing, one way to detect is the slowness of thinking is with tests like this one. This is called the phonemic verbal fluency test. So in this test, we ask the patients or people to produce words starting with a letter, for example, P, within 60 seconds. So they have to say the more words they can during 60 seconds, starting with the letter P. These test results are from a woman, a 47-year-old woman that is in an HD early stage. And as you can see, so she was able to produce some words. So all the words that she said start with the letter P, so they are correct indeed. But the thing, it took her much more time to process the request and to retrieve the right words. So she was only able to find 4 words and to say 4 words during the whole minute, which is less than someone without HD is able to do. So the idea is, with this slowness, what can we do to help patients and families to deal with this? And I think the main strategy is a universal strategy, which is to step on the brakes of our car and go slower ourselves. So the idea is to make our car move at the same speed that the patient's car, so we can do the journey together with him. And this means we have to train ourselves to wait for patients' answers, to speak at a more smooth and slower pace, and try to focus the patient's attention on what is being said or requested. Usually, the more advanced the disease is, the more time the patients take to process and react to what is being requested. So the more time you have to give the patient. So to make it easier and focus the patient's attention, there are several tips about things you can do to improve this. the first one is to pass information in simple phrases with just one main idea, for example. The second thing is to reduce distractors. So for example, if you're speaking with a patient in a very noisy room with the TV on, probably the patient will not hear anything or will not focus the attention on you, but on the TV. So switch off the TV before starting to speak with the person. Another thing is, it's more favorable to do one-to-one interactions than group interactions, for example, at least with some patients, because it's easier to focus in only one person instead of a whole group. Another thing, and this is when you're interacting directly with the patient, is to remember three things. One is to find the right physical distance. So this is tricky, especially in COVID times, but it's manageable. So you have to understand where to put yourself so as the patient can see you well and hear you well. The other thing is to maintain eye contact. So this is especially important if the patient is in a wheelchair or in a bed. So you have to bend yourself and try to level your eyes to the level of the patient's eyes, because it's easier to capture his attention by doing this. And the last thing is to use the name of the patient several times. It's called the cocktail party effect. So this is the more wonderful sound for us and the more familiar word for us, our name. So it's easy to focus our attention when someone says our name, even if the environment is noisy and with lots of other conversations taking place. So I don't know if there are questions or we can move on.
I don't think we have specific questions for this, so I think you should move on also.
Okay.
Conscious of the time.
Poll now, or should we do it?
We can make a poll just to understand if people.
I was just going to say on the questioning thing, with my husband, I find he's got to that stage where asking him questions seems to be too many demands placed on him, and he finds that really difficult and kind of will shut down. You know, he has carers that come in every day now, and we've had to reduce the amount of sort of questions and giving him choices and things like that, because it's almost like it's too much of a demand to sort of speak to him and ask him these things.
Yes, that's very true. So the idea is just keep the message really simple and avoid overwhelming people with questions and information. The opposite of what I'm doing right now, to be honest. But the idea is to keep it simple. So yeah. So another important difficulty that often patients have is difficulty in recalling. But it's important to understand that many times the patients and families come to the hospital and have memory complaints and complaint about memory. But memory impairments are not exactly the main cognitive symptom when we speak about HD, for example, when compared to Alzheimer's disease. So in Alzheimer's disease, memory is indeed the main cognitive symptom. And so it's like the computer had crashed and all the memories and information that were stored in the hard drive were deleted. So the patients don't have any memories or information there. But in Huntington's disease, it's different. So the hard drive of the computer is working. So the memories and the informations are there. The only thing is that retrieving that information, so getting that information and bringing it to the screen is really, really slow, a slow process. But so it's doable, but it takes much, much more time than usual. So the computer is slow in recalling the information, but the information is there. And it's important to distinguish between recall and recognition. So in recall, there's a conscious effort to bring the information back to one's mind. So to use it at the current moment. In recognition, we have to identify between new information and information that we already know. So, and we have to choose from that clues the ones that we want to bring back to the current moment. So there are external cues in recognition to help us identify the information that we have seen before. So in Huntington's disease, recognition is much easier than recall. But in fact, for all of us, recognition is easier than recall. And we'll do now an exercise to prove that. So now you'll need the paper and the pen that I ask you. And I would like to ask you to draw a coin of €1 without going into your pockets or wallets. So please try to do that. 1 minute to do that. So can I show it?
Should we show our results?
Please. Okay, so at least they are all round, not square. Some of them have a number, which is nice also. But the thing is, okay, everyone drew the number and knew that it was round shaped. So, but some of the details probably you just couldn't draw it because you forgot them. So you know them, but when I ask you to remember, it was a little difficult to bring it to your mind, so to recall them. But if I presented, for example, these 3 options and ask you to say which one is the euro coin, it would be easier. No? It would be much more easy for you. So again, the idea is to use this to address recognition instead of recall when dealing with someone with Huntington's disease, because as you see, it's much more easier to recognize than to recall something. And you can do this easily with having notes and to-do lists and schedules and agendas all over your house, setting up the alarm clock whenever there are important things to do, implement routines. So when days are look-alike, it's more easy to remember what's coming next. And also an important thing is to provide clues. And one of the things is exactly what Zoe was saying about questions. So not overwhelming the patient with questions, but making the questions in the right way. And this means closed-ended questions instead of open-ended questions. So, and here's an example of how to do this. So in this example, I'm trying to find out what is the favorite football team of that patient. And I have 3 ways of putting this question. So I can ask, what is your favorite football team? And this is an open-ended question, so free answer. I can provide options, so a multiple choice question, and ask, is your favorite football team Porto, Benfica, or Sporting? Or I can divide these questions into small, brief questions that only need a yes or no answer. So I can ask, is your favorite football team Porto? Is your favorite football team Benfica? Or is your favorite football team Sporting? So, and you can see that each question allows a faster and simpler answer. So it's more useful if you do these closed-ended questions to make it easier for the patient. Another thing, and this is another cognitive problem that causes a lot of trouble, not only for patients, but also for families, is the difficulty focusing and switching attention. So for many patients, it's a problem. They have many problems with multitasking, so doing more than one thing at the same time, dealing with surprises, for example, having a friend coming over without, and they were not expecting. This can cause several problems. Changing routines also can cause lots of anxiety and frustration, or changing the topic in a conversation. So what I'm going to, or the exercise I'm going to propose right now, is to also see that for all of us, it's more challenging when we need to switch attention, when there are when someone demands that we switch attention and then focus our attention. And so to do this, I will need a volunteer, preferably English speaking, so Zoe or someone else. So can you do it, Zoe?
Yeah.
So
yeah, no problem.
So the idea is to do a little exercise using a very old neuropsychological test called Stroop. So it goes back to 1935. And so the idea is, what I'm asking you to do is this. I'd like to ask you to say the color of each word out loud. So to name the color in which the letters of the word are written. And please be as fast and accurate as possible. So when I say, you start on the top and go from left to right as if you were reading a text.
You said this weren't an exam, Filipa.
It's not an exam.
It's the end of the day as well, bearing in mind.
No, it's just, you'll see my point.
Okay.
Can you do that?
Yep.
Please?
Yep.
Okay, so focus on the color of the word. Go. You can start, please.
Blue, red, green, red, blue, 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 green, green, red, green, red, blue, green, green, red, blue, red, red, green, blue, blue, green, red, green.
Perfect. Perfect. How do you feel? 100%.
Confused.
No, but it was not that tiring, right?
Yeah.
You could have continued to do this, and we ran out of words, so you stopped, but it was not that tiring.
No.
So let's try the same, but with these words. So again, I will ask you to say the the name of the color in which the letters of the word are written. So the color of the word, not...
Sorry. So the first one, right, blue is obviously green. I'm saying blue.
No,
yeah?
you will say
green.
You will say green, exactly.
Okay, great, right, okay.
Right, so you'll focus on the color of the word.
Wow, okay. Yeah? All right then, okay.
Let's start. Go
green,
for it.
Green, blue, red, green, green, red, green, red, blue, green, red, blue, green, blue, red, green, red, blue, green, blue, green, red, red, blue, red.
Perfect. Very good. Thank you, Zoe. So how did it feel?
It was much trickier.
Much trickier. So it demands much more of you. So you have to be really focused, right?
Yes.
And it's more tiring, no?
Yes, it is. It's harder. Your brain's got to work double harder than before.
Okay, okay. So that was the point. So this is not an exam, as I said, as Maiken was saying. So the idea is just to try to feel what it might be to have problems with this focusing attention when the demands are switching or change, okay? So everyone feels more tired, that this is more effortful and tiring. So this is how we try to assess this difficulty with conventional tests. Again, is the Stroop test that you did, Zoe. So these are the results of an HD patient. And as you can see, out of 100 possible answers, she only got 25. So it's more difficult, this interference task. And also, sorry, here in this part, you can see that there's another test. This is the MOCA test. It's an interesting exercise. So when you ask someone to subtract 7 from 100, you can see that here the patient was able to subtract 7 from 100, so 93 was correct, but then she started to subtract 10 instead of 7. So all the other answers are wrong because there was this attention flaw there that caused all the answers to go wrong from there. So it's important to really address this. And how can we address this situation? By addressing or choosing one topic, one task at a time. And this can be or can seem really, really simple, but it's really, really difficult if we live in this speed and fast world where everyone has to be a multifunction pocket knife and do 46 things at the same time. So it's really difficult to find a way to do this, but we need to find it. If change is inevitable, and it is in daily life is constantly changing, then we can try to prepare the patient for this change and go slower. And when I say prepare, is just to, for example, give verbal indications. For example, so now we are almost done speaking about your medication, and then we are going to start speaking about your physical activity. This is one way of doing this. Or now we are almost finishing lunch and we are going to prepare to go for a walk. So by saying simple things like this, we are preparing the person for the change that is coming. And so he or she will be more ready and will cope better with that. And again, reduce distractors. So switch off the TV, switch off the music from the car, and so on.
Filipa, I just want to make you aware we are running a little bit close to the time frame we have. So just so you know, I don't know if people have to leave at exactly at 8:30.
Okay. So
but, we can run a little bit over, but just so you know, yeah. Thank you.
So I'll just go briefly through. There are 2 more cognitive changes. This one is one of the main ones in HD, so it's difficulty organizing and planning because it has to do with executive functions. So more than memory, this is the skill or the ability to plan, implement, organize thoughts and actions. This is the most affected area in HD. So it's important to address this. These kind of skills, executive functions, are the skills that, for example, allow a father to answer the daughter request in just 60 seconds, for example. So a daughter asks her father for a ride to the dentist in 2 weeks, and a father without HD usually takes around 6 seconds to answer yes or no. But there are many things going on in the brain during these 6 seconds. So we have to organize, plan, sequence, and respond. So it takes a lot of steps and sub-skills. And the point here, or the idea I want you to take back home, or the take-home message, is that this kind of analysis, or this kind of planning, organizing, implementing, sequencing is, of course, changed with HD. And this can explain many things, such as the incoherence that sometimes you see when the patients say that he will do this, he will go to the doctor on that day, and when the day comes, he says that he will not go and he does not want to go. So, because he said yes, and when he really meant to say no. And this is because all this analysis, all this process is impaired, and so there are steps that the patient skips and does not do properly. And again, this is a test where you can see that. The zoo test, where the idea is to do a path without using the same path more than once. And you see that here the patient uses some paths several times. So he did not plan well this visit to the zoo. So I'll skip this. So the idea to address this problem is just to try to make that turn each task or activity into a kitchen recipe, where all the steps and all the ingredients are written and in the proper order, and the patient just has to follow the list to be able to do this. This will help with the coping and with the planning. Again, the calendars, schedules, agendas, having a routine, avoiding surprises, and offer limited options. So finally, and this is very related to what with Iron's story and with what other people shared in the beginning of the webinar, the difficulty with emotion regulation that many patients have. And this is responsible for the impulsivity, impatience, agitation, anger outbursts, and irritability. But the important thing to do, so this is one of the most distressing cognitive features of HD, not only for patients, but especially for families. And again, what the take-home message is that this is caused by structural and functional changes in the brain. So there's a brain structure called the caudate that works like a gate to regulate all the emotions and the emotional responses that we give. And so what happens in HD, so a normal caudate or a caudate without HD, when there is something, for example, I forgot to bring the keys when I went out of the home for a walk. So a proper caudate will open a little bit only and will allow for a little bit of irritability or frustration to go out and to have this kind of response. But in HD, the gate is damaged, and so is always open, or it's open for too long. And so the little bit of irritability or a little bit of anxiety or whatever turns into this intense and overwhelming emotional response. And so the stimulus is not important. The important is that this gate is not working properly. And this is why the outbursts and the angry and the crying and the shouting happens most of the times. It's because of this. It's like almost like an emotional incontinence. So people are not able to control their emotions, as they are not able to control or regulate their movements. So how can we do, or what can we do to help with this? It's important to say that, again, all patients are different, so you will have to find out the best solution. But the idea is not to shout or confront or start to fight with the patient, because usually that doesn't solve anything, but try to accommodate or try to understand what are the triggers, what are the main triggers of that outbursts and of that reactions, and try to address them. For example, if I understand that my father usually goes crazy because I take too long to get the yogurt from the fridge in the middle of the afternoon, I will try and prevent and anticipate. And so in the morning, I'll pick up the yogurt and put it on the table, and it's there. And so I already anticipated the demand or the request. The other thing is, again, show the patients that there are other ways to get attention, because sometimes the screaming and the shouting can be ways to get your attention. So help them learn new ways to do that. And another important thing is to use clues when doing tasks that you know that the patient doesn't like and can trigger negative emotions. Use clues. For example, when eating the soup, say, okay, we're half done, there's only 10 spoons left, so we are almost over. So for the patient to see that the uncomfortable situation is ending. This is important also. So there are little things that we can do. So this is the final slide. So the idea, and I hope I managed to do this, I'm not sure, but the idea was to make you understand that all these cognitive changes and behavior changes happen because there are brain changes. So everything is connected, and it's not because people are bad or bad intended. The other thing I wanted to show you or to do with you is to show you how it might feel to live with these changes, the slowing, the difficulty with attention, the problems with organizing, and so on. And finally, I want to show you some strategies that hopefully will reduce the impact of these changes on daily life, and I hope it will, some of them at least, will be helpful for you. So yeah, that was this presentation.
Thank you. Really, really interesting and a great talk and presentation, Filipa. I think if you can bear with us that we go over a few more minutes, I think because there is a comment from Zoe, I guess, about her husband really being whining or crying, and I've heard about other patients who do that for reasons you cannot really understand. Do you have any comment to that, Filipa? That kind of all these sounds that you don't really understand, can that be the same, just an emotional incontinence, you said?
No, this is one of the neurologists from the hospital once used this word, emotional incontinence, and I thought it's funny and it's accurate. It's at the same time, and I think it so somehow this control, this ability to inhibit the bad feelings or the negative reactions or the explosive emotions is impaired in Huntington's disease. So as I said, the gate is always open, and
he had to use a lot of medication because it was getting so severe, you know, where he's grabbing himself, flinging himself everywhere, like just distressed and despair is all I can describe it as. And it's obviously I've got young children as well, so it's, you know, it's really trying to do the right things, and you know, I know medication's not always the answer, but it has actually made a big difference.
And many times when things are really getting out of hand, sometimes and it's okay for the patient to be admitted in the hospital for some time just to balance things, because you cannot work anything or improve anything if everything is out of control. And so there are drugs and strategies to help balance.
Yeah, I mean, we're quite lucky. We've really got a good neurological team here, and we've got like a community specialist nurse as well, and they link really well with our GP, you know, so there's quite a nice, good team that link up, and always calling and always looking at ways to try and help. But yeah, this part is definitely the hardest part, you know, because I think there's the OCD part that goes with it, and that affects his mental health as well in the same sort of way.
It's important to have a really open dialogue between neurologists and psychiatrists, because it's all it's important to have that dialogue, because that's a lot to deal with.
Yes.
Thank you so much. I'm a bit conscious about the time, so I feel like we should maybe wind up. And there are a lot of comments here, Filipa, that it went to Eirin also, that it was really helpful and very good talks, presentations. And I want to thank you so much, both of you, for all the efforts you've done. And Eirin, I hope this will help you, but I can assure you that it will help others that you share, because it's the way that we learn and understand ourselves, is to listen to others. And thank you so much for sharing your thoughts about this. And it's really brave of you, really brave. And thank you so much, everybody, for showing up. And what did we do? We wave. We cannot hug, so we wave. Put on your camera and wave if you like.